This is Francisco Caicedo. We're now in part two. We're going to focus now in foot and ankle. So, how we say before, in my opinion, the Atlas of Anatomy Netter is one of the best to help us to see what is under the skin, because that's what we try to see with these instruments, X-rays, CT, MRI, and now the ultrasound. The beauty with this one is very dynamic and very relatively low cost, and is possible to do in the office and the surgical procedure, and very familiar now with the anesthesiologists and rheumatologists and pain treatment. So going back a little bit, the anatomy, so we know the principles. The white, that's mean hyperechoic, is the bone. The black is the cartilage. You can see a very beautiful line. That's the cartilage. How we differentiate with the fluid, you can see the fluid is most irregular, and the pressure they put in the probe, it will help us to make the differentiation. In lateral aspect, the position of the probe is transverse. So we start in identify the hyperechoic structure is the fibula, and then you can see this fibular pattern below, behind of the lateral malleolus. That's the peroneus tendon. You see the configuration. Remember, the ankle and the foot, the anatomic variants are very common. So before we call pathology, or something abnormal, it's better to compare with the contralateral side. It's very, very important that you start first, be familiar with the studies, and also be familiar with the normal anatomy of every patient, and then you start with the contralateral extremity, and then you correlate with the symptoms and the signs of the patient to really interpret the studies, and then it give you a better diagnosis and future treatment. Normal, you can see some fluid, but if it's increased, there can be signs of tenosynovitis or ruptures. Um, in the longitudinal aspect, I always like to start close to the bone. You can see the hyperechoic signal of the fibula, and slide the probe a little bit posterior, and you can see these fibular patterns very well defined, and you can follow them from the insertion in the fifth metatarsal head, and you can see it right there, and follow the trajectory now close to the calcaneus, where they have the insertion of the extensor retinacular inferior and superior, and they have their own tabication that, like I say, is very different in every patient. Now, the follow the trajectory of the tendons. So again, I start from the hyperechoic of the bone, slide gently in the back, and I start from proximal to distal. And two very important details: you can see not only the structure, but you can see the diameter. When you have a pathology, and especially when it's chronic, what you see is thickness. That's one of the signals. And then you can see these patchy anechoic patterns that they tell you that is rupture or degenerative changes. And remember again, this instrument is very sensitive to the inclination. So to truly call pathology, you can see the same findings with different inclination. Because sometimes you can see it in one picture, but you do the inclination and you can see the continuity very nice. So that's also very important to do the correction through the inclination and do the correlation. In this case, you can see one of the peroneus tendon start very symmetric, very irregular pattern. You can see some disruption of the tendon with full fluid collection. So this one represents peroneus tendon rupture. Looking at transverse, so this is the probe we have posterior to the fibula. The fibula is right here. We know that between the fibula, the tip of the fibula, and the calcaneus, there's a strong ligament, the calcaneofibular ligaments. So when we do the probe, we can follow transverse and longitudinal. And in the top, the first big structure you can see is on the peroneus tendons, longus and brevis. And underneath, you can see hypoechoic signal is the ligament. So how we know is the ligament, how we know we have a pathology? Again, the active motion, when you do the force inversion, you can see how the ligament is stretched out. And if it's a gap, you can see the black or the anechoic signals. So that's a very good test to evaluate um, the incompetence of the normal and the thickness of these ligaments. The routine, I start with the top of the ankle, so you can see very nicely the hyperechoic signals of the talus, and very nice line is the cartilage. And you can see some irregularity here, not necessarily means pathology of the cartilage, is the fluid that depend on the pressure I put, I can modify these lines. And then you pay attention to the superficial structure that you can see more in the middle, the neurovascular bundles, and more in the lateral and medial side, the tendons. So here again, you can see the talus, you can see the capsule, the cartilage. If we go more proximal between the tibia and the fibula, we can start seeing the syndesmosis, and it's reflected right here. In the more inferiorly, we know that the ATF, that means the anterior talofibular ligament, is a little more inferior to the shoulder or the talus. So you can see here the talus, we can see the shoulder, the talus, but we need to go a little bit down, and that's when you identify your ATF ligament. Um, Going back to the plantar area, so remember the plantar fascia has two components, the medial and the lateral. So most of the pathology is medial. So you can see here, and with the bone, the atlas of Netter, the calcaneus, and the sharp fibers, and the black, you can see it is part of the cartilage that sometimes is present on the bursa. And we evaluate the distribution of this fibrillar pattern. And again, when you have pathology, especially it's chronic, you see the thickness. This is signs for pathology, and you can start seeing some patchy anechoic signals, and also show you there is some disease in that plantar fascia. Now we go in the Achilles tendon. That's the insertional Achilles tendon. Normal, you can see some irregularity. That's not completely abnormal, but you can evaluate the presence or the absence of these bursas. They help you to lubricate and and be functional for patients with a normal Achilles, or they can be a problem creating a sandwich impingement in patients with insertional Achilles tendinitis. So you can see very clearly in the anatomy of the atlas of the Netter, the pouch, and you can see here, and you can see the fibers getting to insert in the calcaneus in the inferior posterior aspect of them. And then we follow longitudinal the Achilles tendon, and you can see a very symmetric pattern very nicely. And again, here we can see this fusiform deformity with patchy anechoic signals, show me that this patient in this case has a non-insertional Achilles tendinitis. And here you can see very clearly. And when you palpate it, and you can still see it, and you palpate it, patient jump is very painful. So you always have the correlation, and that's the beauty for the clinicians, where you can see, you can feel, and you can show to the patient. So this is a very good instrument for all the orthopedic surgeons and clinicians. Another very important factor, we can do Doppler color, and they can show you the circulation and also inflammatory factors. It's so graphic and so beautiful that when it's red, that means it's artery because the velocity of the flow. And when it's less flow, you see blue. So it's amazing how didactic is this is instrumentation. So why is important? Because remember, the pathology and the anatomy changes dramatically in every patient. So you can see it in this patient. What is the location of the innervation and the irrigation? So with that one, you can plan in what kind of approach you can do. You can do more middle, you can do more lateral, and you can do more posterior. And this is one of the principles that now you can see in Europe, the use of the ultrasound in surgery. When you can do echolocation, you try to identify these areas when they have a neogenesis or neovascularization. So you can do more selective surgery using radiofrequency, or sometimes you can use shock wave therapy, or use some mesenchymal factors present in the plasma-rich platelets or platelet-rich plasma, or some mesenchymal cells obtained from other part of the body. So in this case, you can see there is some inflammatory factors. This patient has a chronic tendinitis, and then this is one of the factors that most likely is the cause for the pain in this patient. And again, that's a beautiful picture. You have here the calcaneus, the insertion of the Achilles tendon. If we go more proximal, you can see the gap. This black anechoic is present in all the inclinations, so that means it's real. The patient has pain. And one of the patterns that I always see it is the rupture or the degeneration of the non-insertional Achilles tendinitis, or the rupture is more in the core, that's meaning the center. And that probably explains the anatomy and the embryology of the Achilles tendon. Remember, the Achilles tendon don't run completely longitudinal. When they have the insertion, they have like a torsional insertional, very interesting, the lateral and the medial component. So that's why there is a pattern to know what part is usually more damaged. And you can see it's like AM, like in the morning, and PM in the afternoon. So the AM usually is the one who got more injury. And going back to the insertion Achilles tendinitis, when the patient has a chronic gastrocnemius contraction and the patient has multiple micro ruptures, the body got tired to repair, so try to make it stronger. So actually, when you do the histology, you don't see calcification, you will see or ossification. And these are factors for pain and limited. So again, this is a very nice imagine that it can be used by surgeon in ultrasound assisted surgeries, where we can be more selective and treat this pathology. And it's crucial for athletics with the high elite competition, our soccer players, where they don't have the opportunity to be down for 6 months or 8 months. So being selective, hopefully we can help them. Of course, this is just the beginning. We don't know the final outcome, but I think this is a very promising technology to help our patients and in the sport community. And like I say, the atlas on errors so show us what is under the skin. Also, the ultrasound can show artifacts or structure. You can see the head of the screws and the metal. This patient has a fracture of the fibula being fixed with the open reduction tunnel fixation, and you have see the plate. And this is the pattern that you can see when they have metal in the body. One other pathology, you can see the osteochondral lesion of the talus. These patients, you can see the fluid is increasing. The beautiful pattern is not anymore, and you can see like a little bite. So that means is a damage of the osteochondral in the shoulder. So it's impressive. You can see the osteochondral lesions when they have involvement of the osteochondral bone in the talus. Again, in the transverse aspect of the peroneus tendon, you can see only one tendon, and very amorphous signal is the tenosynovitis. Patient has a chronic peroneal tenosynovitis with rupture of the tendon. When you do the dynamic text, you only see one tendon. And here in these patients, so we go proximal, and we found in the about 4 or 5 centimeters, actually, you can see what exactly is the lesion. You can see a rupture of the Achilles. So you can plan your surgery and your incision. Medial aspect is very beautiful and very excited to show you this. I call the Mickey Mouse signs. And Mickey Mouse means the head is the artery and the veins is the ears. And when the patient has a contraction of the gastrocnemius, they change the way they walk on it, and they try to do hyperpronection. That produces stress in the posterior tibial tendon, and they can do a tenosynovitis. So also decreasing of the arch for laxity of the spring ligament. And you can see here is a strong, thick tissue. That's the deep fascia or the extensor of the abductor of the